Good afternoon, respected Chief Sir, faculty members, and my colleagues. I'll be presenting today on cornea retrieval and eye banking. Corneal blindness is a major form of visual deprivation. There is a high potential of visual rehabilitation by corneal transplantation with high success rates as compared to other organ transplantations. So basically, cornea retrieval can be a whole globe retrieval, which is done after enucleation, or it can be an in situ corneoscleral rim excision. There are various prerequisites for a cornea retrieval. Donor age, there is no age limit for any donor. All the donors can be determined on individual case-to-case basis. Interval between death, enucleation, excision and preservation is usually between 12 hours of death. And before proceeding for any cornea retrieval, you should be ensured with the location of the donation, age of the donor, and cause and time of death. Now, there are various contraindications of eye coil. There are many infections which have a contraindication for eye coil and retrieval, which can be systemic infections at the time of death or local eye infections. The various systemic infections are HIV/AIDS, hepatitis B and C, syphilis, septicemia, wherein the patient had a total leukocyte count of more than 14,000, fever at the time of death, and positive blood culture. Other diseases are rabies, tetanus, various viral diseases, malaria, and miliary tuberculosis. A new addition to this list is the COVID-19 virus infection. The other local eye infections can be conjunctivitis, pus discharge from the eye, and corneal ulcer. Various malignancies are also contraindicated for eye coil. Systemic malignancies include leukemia and lymphoma, and local eye malignancies are retinoblastoma, malignant melanoma, and metastatic tumor in the eye. Neurological diseases are also contraindications for eye coil, which can be Alzheimer's disease, dementia, Parkinson's disease, Creutzfeldt-Jakob disease, and unknown neurological diseases. Other than that, patients who had been on ventilator for more than 72 hours, or cases of cyanide poisoning, congenital rubella, Reye syndrome, or death due to unknown causes also are contraindicated for eye coil. Then what changed in the year 2020? Before any eye coil or eye retrieval, we need a negative COVID-19 report. This is only precautionary so as to prevent the spread of the virus infection. And cornea retrieval is being done under hospital corneal retrieval program. And voluntary donation is done if the test report is negative within 72 hours of the death. Then in situ corneoscleral rim recovery. Recovery is basically retrieval of organs or tissues from a deceased organ donor. Various steps are followed in the procedure. First of all is the maintenance of donor corneal tissue before recovery. Then we follow various preparatory steps before proceeding for the retrieval. Donor blood collection is to be done before the cornea is retrieved. Sterile supplies are to be opened in a clean and dry surface. Then preparation of donor, followed by corneoscleral rim excision and storage of the tissue. Now, eye care is important to prevent the infiltrates and epithelial exposure of the cornea. This is done by keeping the eyelids closed and use of moist cotton pads. Ophthalmic drugs such as antibiotics, balanced salt solution, and sterile saline can also be used for the same. And we have to elevate the donor's head and upper body so as to prevent pooling of blood and fluid in the head and neck area and reduce edema in that area. Before proceeding further, the consent has to be verified duly, which is signed by a legal relative in the presence of two witnesses and has to be cross-checked and signed by the doctor and technician which are recovering the donor cornea with date and time clearly mentioned. The medical chart has to be reviewed thoroughly. Any history of systemic illness, cause of death has to be noted. The donor is identified by the use of wristband or toe tag if in a hospital or from a legal relative. Before proceeding further, don protective clothing like gown, cap, mask, face shield and gloves. Physical assessment of the patient of the donor is to be done. Look for any needle track injury marks, body piercings or tattoos, moles, melanomas, warts or gross signs of any infections or injuries. On a torchlight examination of the eye, look for any debris, abnormal cornea size or shape, epithelial defects, corneal opacities, anterior chamber depth, haziness of the aqueous humor, lens status, and evidence of gross blood present in the eyes. The donor blood is to be collected before the cornea is retrieved. This is must, and Around 10 ml of blood is required, which is usually taken from the subclavian vein, cardiac puncture, or femoral vein, since the other veins usually collapse after death. And immediately after retrieving the blood is to be transferred to vacutainer tubes. The sterile supplies are opened on clean and dry surface. The surface is thoroughly decontaminated with any disinfectant spray and then dried before opening the items. Usually 2 sterile drapes, cotton pads and povidone iodine solution both in 5% and 10% concentration are required. The instruments required are artery forceps, lid speculum, conjunctival scissors, a BP handle with 11 number blade, Castro-Vizio scissors, both right and left, forceps and globe fixation forceps. The donor's head has to be elevated again to prevent pooling of blood in the orbital areas and to reduce the edema present in that area. Before proceeding, copious irrigation of the conjunctival sac and cornea is to be done with a balanced salt solution so as to remove any debris and dust particles present. The eyelids and periorbital area is cleaned with 10% povidone iodine solution. Irrigation of the cul-de-sac with 5% povidone iodine is done. This is allowed to sit for 3 minutes and the procedure is repeated thrice. Then it is rinsed with a balanced salt solution in nasal to temporal direction so as to wash away whole of the solution from the eye. After this, a sterile drape is put on the eye. The lids are opened using speculum. 360-degree conjunctival peritomy is done. Then the limbus is marked 2 to 4 mm on the sclera. Then using 11 number blade, a 5 mm incision is made through the sclera and avoid puncturing the choroid. Then continue scleral rim excision 360 degree using Castro-Vizio scissors without perforating the choroid. The iris and ciliary body is gently pushed away using atraumatic forceps. While doing so, avoid bending the cornea or touching the endothelium. The cornea is then inspected for any residual iris or debris and if present are removed using the forceps. The rim is placed in a storage medium under aseptic conditions, and after that any artificial eye conformer is placed in the eye and eyelids are closed. So this is a short video. A thorough cleaning, a wash of the cul-de-sac is given with a 5% povidone iodine solution and allowed to stay for 3 minutes. Then cleaning of the periorbital area with 10% povidone iodine solution is done. After that, a BSS wash is given so as to remove any remnants of the povidone iodine solution. Draping is done and speculum is placed. A 360-degree conjunctival peritomy is done using conjunctival scissors. The peritomy has to be done completely around the limbus. After that, using a 15 number blade, remove any remnants of the Tenon's capsule or any conjunctival tissue remnants from the sclera around. Make sure that you do not injure the cornea at this procedure. After this, 1 to 2 mm incision is made onto the sclera around 2 to 4 mm from the limbus, and using Castro-Vizio scissors both right and left we excise the scleral rim. During this procedure, make sure that you do not puncture the choroid. After the sclera is excised, we gently push the iris tissue away from the cornea using atraumatic forceps, and then this corneoscleral rim is transferred to a sterile vial and a corneal cap is placed. After retrieval, the corneoscleral rim is placed under aseptic conditions in a clear bottle containing McCary-Kaufman medium. It is placed with the endothelial side up. Avoid touching the rims to the sides of the bottle while placing the tissue. The vial is thoroughly labeled and then transported to the eye bank in an insulated box with ice packs and the completed forms attached with it. The collected blood sample before the use of the cornea is used for serological testing. VDRL is done for syphilis, anti-HIV and 2 antibodies, HBsAg and anti-HCV antibodies. The cornea is not to be used until the sample is reported as non-reactive. Then in the eye bank, the donor cornea is evaluated. All the donor characteristics are checked. Gross examination, slit lamp examination and specular microscopy is performed on the retrieved cornea. The various donor characteristics that are checked are the donor age. It is reported that graft survival is independent of the donor age, but the infant cornea is more elastic and thick. The death to excision time, which is DET, is usually acceptable up to 12 hours. A negative donor serology for HIV, HBsAg and VDRL is to be there. And COVID-19 testing these days with a RT-PCR report has to be there. The cornea is grossly examined for the corneal clarity, any epithelial defects, presence of any foreign body, arcus, corneal opacities, residual iris and keratic precipitates. On slit lamp examination, we do it when the tissue is mounted on a tissue holder and placed on the slit lamp. On diffuse illumination, we look for any epithelial defects, opacities, band-shaped keratopathy and pterygium. On the slits, we look for stromal or endothelial scars, stromal thickness and edema, any foreign body and decimate membrane folds. Specular reflection is done to look for the status of endothelium and any cell dropout areas. Then specular microscopy is done to look for the status of the endothelium. Cell density is basically the number of endothelial cells present per millimeter square. Then CV is coefficient of variation. Normally it should be 0.2 to 0.3. Hexagonality is a percentage of hexagonal cells. More than 50% of hexagonality is desirable. Then we divide the donor cornea into 3 grades: optical grade, therapeutic grade and not suitable for surgery. This was given by the Cornea Donor Study based on characteristics of the epithelium, stroma, decimate folds, endothelium and specular count. If the epithelial defects of 50% or less, a haze of none to more than moderate, an exposure of none to more than moderate is there, with a none to more than mild stromal edema and an arcus which is present in beyond the 8 mm clear zone, with no or to mild decimate folds and no true guttae and a specular count of more than 2000, then it's an optical grade tissue. A therapeutic grade tissue is the one where the epithelial haze is moderate to severe with a mild to moderate edema and decimate folds and a specular count ranging from 1500 to 1999 per millimeter square. Any tissue with severe haze, edema and severe folds with the cell count less than 1499 is considered not suitable for surgery. Now, grading of severity of decimate folds: if there are no decimate fold present, then it is considered as baseline. Trace folds are considered when the folds are 0 to 10% above the baseline. Mild folds are 11 to 15% above the baseline. Moderate folds are 16 to 25% above the baseline, and severe folds are more than 25% above the baseline. Now, this grading was given from RP Center. It was basically described in a whole globe, and the tissue is graded into A+, A, B+, B and B- based on characteristics of the decimate folds, corneal thickness, stromal haze and specular count. When there are no decimate folds, the corneal thickness is normal and there is no stromal haze with a cell count of more than 3000, we grade it as
this
excellent.
is published. Navneet, this is published.
Yes, sir.
Where is the reference? Okay, fine. It's okay. It's okay.
Then the donor cornea is preserved to maintain the viable state of the cornea between retrieval and transplantation. Now, what is an ideal preservative? It's the one which maintains endothelial viability, maintains corneal clarity, maintains pachymetry, is cost effective, is sterile and maintains sterility, leads to easy transportation of tissue and gives unlimited preservation. Now, storage media can be divided into short term, intermediate term and long term based on the number of days the tissue can be stored. Short-term storage media include moist chamber, which provides preservation up to 24 hours, and McCary-Kaufman and modified McCary-Kaufman media. Intermediate term storage media are Optisol, K-Sol, Dexol, Usol C, Cornisol and Optisol GS, which provide storage up to 10 to 14 days. And long-term is organ culture media, glycerine and cryopreservation, which provides indefinite storage. The tissue is stored aseptically at a temperature which is appropriate to the method of preservation used, and while storing, a temperature log is maintained. If there is any change in color of the vial, then the storage media is considered as ineffective and the tissue is not to be used. The donor cornea is distributed after a thorough review of the donor medical history prior to distribution or transplantation by the ophthalmologist. We have to ensure a fair and equitable distribution and also distribution to other eye banks where needed. Now, the patients registered for keratoplasty are also categorized into 4 types based on the requirement. Emergency patients are the ones which require emergency therapeutic keratoplasty, such as patients with impending corneal perforation, or patients with perforated corneal ulcer, or pediatric keratoplasty for children less than 10 years of age. Top priority patients are bilaterally blind patients with the best corrected visual acuity of less than or equal to 3/16 in the better eye, or patients with progressive corneal disease who are suitable for endothelial keratoplasty. Priority patients are the ones with bilateral corneal disease with better eye best corrected visual acuity of less than equal to 6/60, and general category patients are patients more than 10 years of age with unilateral corneal blindness. We can also use pre-cut tissue, which is mainly used in cases of endothelial keratoplasty. The donor corneas for endothelial keratoplasty in a pre-cut tissue is usually prepared by the eye bank personnel. The advantage of this is that it increases operating room efficiency, minimizes tissue wastage, and also allows for the preoperative measurement of the lenticule thickness and endothelial cell density. Various studies suggest that with the pre-cut tissue, it gives a low tissue processing failure rate and excellent quality of the surgery. There is comparable endothelial cell loss, visual outcomes, and detachment rates between the eye bank and surgeon prepared tissue. Also, fungal and bacterial contamination rates and clinical infection rates are no higher for eye bank prepared endothelial keratoplasty tissue than for a penetrating keratoplasty and for anterior lamellar keratoplasty. Somewhat about the history of eye banking. It started in the year 1906 when Edward Zerm performed the first human corneal transplantation. In 1944, R. Townley Peyton established the world's first eye bank in New York, followed by the first eye bank in India at Regional Institute of Ophthalmology, Madras, now Chennai, in 1945. In 1989, Eye Bank Association of India was established. And in 1991, Hospital Cornea Retrieval program was started in India. In New York, followed by the first eye bank in India at Regional Institute of Ophthalmology, Madras, now Chennai. The eye banking system can be then further divided into eye donation center, eye bank, and eye bank training center. Eye donation centers are affiliated to eye banks, and they usually spread awareness about eye donation, harvest corneal tissue, collect blood for serology, and ensure safe transportation of tissue to the eye bank. The eye bank provides a round-the-clock public response system for eye donation and also harvests corneal tissue, processes, preserves, and evaluates the corneal tissue, and distributes the tissue in an equitable manner. An eye bank training center, in addition to the functions of an eye bank, also helps in the training of personnel in eye banking and research. Eye donation modalities can be hospital corneal retrieval program and voluntary eye donation. A little bit about the medical legal aspects of eye banking. The Indian Human Organ Transplantation Act, which was given in 1994, states the regulation of removal, storage, and transplantation of the human organs for therapeutic purposes. Under this act, all the hospitals and eye banks have to be registered by the government, and eye and corneal removal can be executed anywhere at home or in hospital. All the organs which are to be donated are distributed without any charge. The person can authorize for the removal of human organs before death for therapeutic purposes, which can be given in writing and in the presence of 2 or more witnesses, at least one of whom is a near relative of that patient. If no authorities was made before the death and also no objection was expressed, the person lawfully in possession of the dead body may authorize the removal of any human organ for therapeutic purposes. If the body is unclaimed and is present in the hospital or a prison for more than 48 hours, the person in charge of the management can also give the authority for eye donation. And if the authority believes that any near relative of the deceased is likely to claim the body, even though he or she hasn't come forward, he can also withhold the donation. Then the amendment of the act was made in 2011, which is now known as the Transplantation of Human Organs Amendment Act 2011. It was notified in the Gazette of India in 2014. After this act, the expansion of the term near relative was done. It included grandparents and grandchildren, in addition to the spouse, son, daughter, father, mother, brother, or sister. Also, the technicians who can retrieve eye or cornea were expanded. It includes duly trained ophthalmologists, registered medical practitioners, nurses, optometrists, refractionists, paramedical ophthalmic assistants. Thank you.
Nice lecture.
Good afternoon, one and all. I am Dr. Anisha, SR Unit 2, and I will be presenting the basics of vitrectomy system and surgery. I will be dealing the topic in the following subheadings. Can we touch vitreous and go unpunished? This was a major question in 1960s because such was the sanctity of the vitreous in 1960s and early 70s. But David Kastner went ahead with open sky vitrectomy to remove the opaque vitreous in primary amyloidosis patients. This paved the way for Robert Latimer, who performed the first pars plana vitrectomy via VISC or the vitreous infusion suction cutter, all in one of 17 gauge force and 1 cut per second. In the later advances, new gauges came like 20 gauge by Conner O'Malley, 25 by Fuji, 23 by Icard, and the recent in 2010 27 gauge by Oshima. So before going to the basics of vitrectomy, we should understand what are the indications of vitreoretinal surgery. It can be divided into therapeutic and diagnostic. For therapeutic, it can be done for a retinosgenous retinal detachment, for fractional retinal detachments like diabetic retinopathy of prematurity. For pars plana, just for a vitreous pars plana vitrectomy, we can go ahead with endophthalmitis, posterior dislocated IOL, MAC hole, epiretinal membrane, and submacular bead. For diagnostic purposes, it is done in endophthalmitis and uveitis. Pars plana is a thin and relatively avascular structure, so it is an ideal access for the sclerotomy incision. Sclerotomy entry from the limbus in phakic is done at 4 mm, in pseudophakic at 3.5 mm, and in aphakics at 3 mm. In cases of pediatrics less than 3 years of age, we usually go as per the incision is made as per the age of the child. Before going to the VR surgery, we should understand what things do we need in the VR or OT. So the basics like a vitals monitor, suction lines, operating microscope, inverter and laser filter, video display, vitrectomy system, a foot switches attached to the vitrectomy system, instrument trolley, operating table, wrist rest, height adjustable surgeon chair with hand, cryo unit, and an indirect ophthalmoscopy and lenses should be there. Recently, we have acquired a 3D VR visualization system or heads up, that is a digitally assisted visualization system consisting of 3 components of 1080 pixel cameras, processing unit, 55 inches 4K display. VR surgeries are performed by looking at the 3D screen with passive polarized glasses. Different filters are used to enhance the visualization of various structures. The benefits were improved ergonomics, there were lesser backache and neck pain for the surgeon, decreased phototoxicity, a better view, enhanced depth, and a better stereopsis. Moreover, there was lesser glare, asthenopia, and as everybody was able to see what is going on in the surgery, it was a very good teaching tool. Microscopic integrated OCT is also used in our ORs, which is an SD-OCT imaging, and you can see it is very useful in macular hole surgeries, ERM removals, and VMTs, where you can see the It is like a histological section of the retina which you can see, but that is non-invasive. With different studies has been done, like Pioneer and Discover study on MIOCTs. For visualizing retina, we should go for VAVS, that is a wide angle visualization system. In this, we have contact system, non-contact system, and endoscopic system. The most common contact lenses used are the Macumer irrigating contact lenses, Vogue reinverting operating lens system, and Chelum lenses. In the contact-based system, we have a wide-angle viewing. Work in periphery is possible and decreased abrasion and reflections, yet it needs a skill assistant. So for that, we have a non-contact-based visual. Non-contact-based, no assistance is required, but there is a 10% less field of view as compared to the contact system, and moreover, more ocular rotation is needed to see the periphery. So these are the common lenses which we use in wide-angle visualization. The common one which you can see in our OT is the Mini Quad XL with a field of view of 134 degree. Irrigating lens or the Macumer, there are two types, 90 diopter and 45 diopter concave lenses, in which we use 45 degree more. Then comes the Chelum lenses, which is a self-stabilized with rest on the sclera due to the negative suction. It was developed by an Indian ophthalmologist, Dr. K.V. Chelum, and it does not need any skilled assistant. So the component of a wide angle system, it consists of a two optical lens system. There's an inferior contact lens element of 7.7 mm radius of curvature, and just above 0.5 mm anterior to it is a superior biconvex aspherical lens. So the overall the system makes up effective power of 150 diopter in air. So in the non-contact visualized system, we have ReSight in our OT. It is a sterilizable aspherical lenses are used. The green lens is used for the periphery, whereas the yellow lenses are used to see the macula. Now we come to the instrumentation. The general instruments which are used in VR are a wire speculum, a plain forceps, a
Power of the lenses.
Sir?
What is the power of these lenses?
So 68 diopter and 128 diopter, sir.
Right.
The accessory instruments which we use in a VR tray are the microvitreal scissors like the ILM forceps and the end grasping forceps, the serrated forceps, horizontal and vertical scissors are used, foreign body forceps to remove the foreign body, and diamond dusted forceps to scrape
It's also
over
very
the retina.
difficult to use curved scissors.
Yes, sir. Curved and horizontal and scissors. Yes, sir.
Oh, nobody uses horizontal. Hardly anybody uses vertical. Curved scissors is very useful because it's like a hook.
Okay, sir.
It also cuts and it picks up. It lifts up and cuts.
Yes, sir.
Because it's curved. So nobody uses horizontal and vertical now. Everybody uses because of risk of causing a retinal break.
Okay.
So speak practically.
Okay, sir.
Don't give, like everybody likes to give theoretical things. Our center is known for it. So we need practical, actually what we are doing.
Okay, sir. This is a VR tray which we use in normal days. It has a conjunctival scissor, the plug forceps if we are using a non-walled ports, then a limbs forceps, the viscoelastic, the microvitreal scissors and forceps, then an irrigating lens, the BSS, then 8th is your BBG dye which we use for chromovitrectomy, then the PFCL, 10th is your subconj injection, then 11th is your vitreous suture to suture the ports, 12th is a needle holder, 13 is a globe fixation forceps, and 14 is your Trocar-cannula system. Now we come to the Trocar-cannula. The basic is the outer diameter of vitrectomy instrument is given as gauge. Higher the gauge, smaller is the outer diameter. The Trocar-cannula system is used because less traction is given on the vitreous base on entry and exit. The cannula maintains the alignment between sclera and conjunctiva and is less traumatic to the wound borders. Recently, a new patented design has come called the Edge plus Trocar system, in which the earliest Trocars which we were using, they used to make a V-shaped incision over the sclera. But in this, it makes a linear incision. In this way, it is not cutting the scleral fibers, but it is making a separation between the scleral fibers. So there is a like self-sealing wounds are made in such cases. Inferiorly, you can see there is a 23 gauge Trocar-cannula system where you can see the micro cannula and the Trocars. These three are the most, in the right side you can see 3 Trocar-cannulas which are most commonly used in our OTs, and they have a designated color for each gauge. For orange you have 23 gauge, for 25 gauge it's blue green, and for the 27, the recent one, it's the violet color. So initially the vitrectomy started with a 20 gauge vitrectomy, but we do not use it that often, just in case of phragmatomy. Or phragmatomy is a 20 gauge vitrectomy which we do, but mostly it is in association with the other cannula system, so it forms a kind of hybrid vitrectomy in which we combine different gauges in a surgical technique. MIVS is a minimally invasive vitreoretinal surgeries which includes 23 gauge, 25 gauge and 27 gauge. Previously, it was known as a transconjunctival sutureless vitrectomy, but we prefer to suture our wounds in order to prevent the postoperative hypotony and the chances of endophthalmitis. So, two types of cannulas you can see. First is a non-walled cannula, where every time when you are taking out the instrument out, you have to put the plugs, and the other are the walled cannulas, where you will have a precise IOP control and there is no need of plugs. Now comes the Trocar-cannula system. You can see the specifications of the micro cannula and the Trocar in 23 as well as in the 25 gauge Trocar-cannula system. Infusion cannula, when we used to use 20 gauge cannulas, it was a 2.5, 4 mm and 6 mm. It was a flanged and it used to be secured with bicural sutures. But currently the cannulas are self-retaining cannulas, and we can use either 23 gauge, 25 or 27. In illumination, it can be two types, the endo illumination.
Anusha, one second. Anusha, how do you create a wound, sclerotomy wound in the case of a MIVS system?
Sir,
That is really what?
Sir, in this first we have to displace conjunctiva somewhat towards the inner side. Then we have to go parallel to the limbus, at least 50 degree, at least 50% within the sclera. You have to go at an angle of 30 degree. And then you have to go with, after reaching the 50% of the sclera, we have to go within the vitreous cavity. So it makes a kind of biplanar incision.
That's good. So you make a biplanar incision. You can make it 5, 10 or something, they call it, depending on the beveled and then vertical down. So by making a beveled incision or biplanar, what is the advantage?
Sir, the chances of vitreous wick and the chances of going
So it is a self-sealing incision.
Self-sealing, yes, sir.
Because of self-sealing, you may sometimes get away without suturing.
Yes, sir.
Okay, continue.
Sir, the illumination can be either endo illumination or external illumination. Currently, we are using the xenon straight light illuminators. The other light sources are used are halogen, metal halide lamps, LED and mercury vapor. Chandelier illumination is also used sometimes when we want to do a bimanual surgery. It gives a diffuse illumination of 106 degree. Sometimes some new instruments are in experimentation where they have incorporated light source within the forceps and the scissor. And in external illumination, we have slit lamp illumination attached to microscope and the office system. The vitrectomy probes, now we come to the main probes which we use in vitrectomy. The probes can be two types, the electrical and the pneumatic. The electrical uses the drive motor and it's heavier, and currently it's not used. The pneumatic one uses the pressurized air to drive the diaphragm inner tube forward, and it's lightweight. Currently we can see that in the photo there's a the parts of the vitrectomy system. It has a cutter housing and a cutter tip. In the cutter housing you can have a motor, a diaphragm and a spring, and in the cutter tip you have the concentric steel tubes which you can see during vitrectomy. And the cutting mechanism can be guillotine, in which the cutter will move like a guillotine and it will cut the vitreous. In rotatory it moves 360 degree and it cuts the vitreous via shearing force. In oscillatory it cuts 360 degree with an shearing force. And in rotatory it's just like oscillatory, but it's like that it moves 180 degree in one side and 180 degree on the other side. Mostly our cutters are the guillotine kind of cutters. Now the cutter mechanism. What is a cut rate? A cut rate represents movement of blade to cut engaged bit, aspiration of that bit and return the blade to the neutral. So from this we can derive what is a duty cycle. The amount of time port remain open for each duty cycle is called the duty cycle of that cycle. Amount of time the port remains open. So please remember this. I'll be dealing with the different modes and what are the uses of those modes like core, shave and 50-50 when I'll explain you the vitrectomy system. So the driving mechanism which I told in vitrectomy probes is the electrical, where the duty cycle is fixed at 50%, whereas pneumatic come in two types. The conventional type where we have a spring for recoil, and the double pneumatic probes where we have a dual pneumatic chamber which helps the diaphragm to go back into the normal position. So this is a conventional spring based vitrector. You can see a spring is there. Usually then the spring based cutters, the cut rate cannot increase so much because of the spring. So it can reach only up to 2500 cuts per minute. The pneumatic pushes the cutter to one direction, and the passive recoil of the spring returns the blade to its normal position. But in the ultra-wide dual pneumatic cutter, which we are using currently, it uses separate air lines to control the opening and closing of the cutter, and it reaches up to 7,500 to 10,000 cuts per minute, and duty cycle can be set in such cases. Then comes the newer version called two-dimensional cutter. In this, the double-sided blade cuts in both directions, the forward as well as the reverse direction. So the cut rate is increased in such cases up to 16,000 cuts per minute. The high duty cycle is achieved because the port is nearly open up to all the time. So the duty cycle is almost 92% in such cases. So vitrectomy cutter, because of the recent modifications, some problems have also arisen, like the rigidity of the cutter. Smaller the gauge, more thinner will be the instrument, hence more malleable. Hence the new innovations came like 25 plus and 27 gauge, which have a 5 mm supporting sleeve near the proximal end to keep it straight and rigid. But it is not very effective for the 27 gauge. And they have reduced the effective length of the instrument. Like your 25 gauge was around 32 mm, and 27 gauge is around 25 mm. So reducing the length of the instrument also has increased the rigidity of the cutter. So a larger gauge cutter like 27 gauge cannot be used in high myopic eyes. So cutting port of these now cutting port of these probe is closer to the distal end of the tip. You can see in 27 gauge the port is very close to the distal end, so it gives an access to the tighter tissue plane. So the instrument can be used to remove, vitrectomy cutter can be used to remove epiretinal membrane, and in cases of diabetic fractional membranes. Now the recent innovation is a hypersonic vitrectomy cutter, in which uses the ultrasonic energy, and it has a 27 to 31 kilohertz of frequency. It liquefies the vitreous and then it is aspirated inside, and so the duty cycle of the port is always open, and the cut rate is up to 1.7 million cuts per minute. Now we come to the aspiration. Aspiration can be active or passive. The active aspiration is when you press the foot pedal and then you are aspirating. So it is used by an extrusion cannula to lift the hyaloid, or do an air fluid exchange, or an aspiration of SRF. The passive is via backflush probe, when you do not press the foot pedal, and via the capillary action the fluid is coming up. It is finger controlled when you close the hole which is there on the extrusion cannula. Now comes the phragmatome. The tip of a vitrectomy phragmatome is longer than a typical phacoemulsification probe. It works on the principle of ultrasonic emulsification, and it is inserted via localized peritomy 20 gauge via an MVR entry. Viscous fluid injection, a syringe is needed with needle of 23, 25 and 27 gauge. And endophotocoagulation probes are used to treat retinal tears, doing retinopexy, or for pan-retinal photocoagulation. We use pure point laser probe. Microscope should always be fitted with the filters, and Constellation 532 nanometers green laser is used. In endodiathermy is used to control the bleeding, for draining the retinotomy and marking the breaks. Constellation uses bipolar diathermy. In magnets, you can have an intraocular magnets and extraocular magnets to remove the magnetic foreign bodies.
Is it bipolar bimanual or bipolar unimanual?
Sir, bipolar unimanual, sir.
Unimanual, so it's got a single probe.
Yes, sir.
Single tip. So it's a bipolar unimanual diathermy.
Yes, sir.
What do you use it for?
Sir, basically first in cases of RD to mark the breaks, in cases of TRDs and all to stop the bleeding, and for drainage retinotomy also we first diathermy and then we drain the SRF.
Right.
Basically there are 3 vitrectomy systems available. We have a Constellation vitrectomy system, and the essential of a vitrectomy machine is an ultravit cutter. I'll be explaining what is that. A dual pneumatic action, and it can reach up to 10,000 cuts per minute. Constellation comes with a variable duty cycle control, which is a very good feature of this machine. Then comes the vented gas forced infusion with an IOP compensation, dual port xenon illumination with a radio frequency identification. Radio frequency identification is a feature of the illumination system, in which it can detect the amount of gauge which you are using. With that only it can adjust the light illumination which is going inside the eye. And the pure point 532 nanometer laser and ozone phacoemulsification. This is the console.
What is the role of the VGFI?
Sir, VGFI, in this the gas is forced for the infusion thing, sir. And we can do interface vitrectomies in this case, sir, in VGFI
See,
cases.
from IOP of 15 or 20, you increase the IOP to how much?
60, sir.
60. Why do you want to increase the IOP to 60 millimeters, which can cause CRA occlusion? But also, what is the advantage? For a few seconds, if you can increase it to 60.
Lag phase is not there in between to hypotony and CD can occur if there is some amount of lag phase. In cases of gravity pumps, it can happen, but fluctuations will be less in cases of VGF.
In diabetic vitrectomies, when there is bleeding, profuse bleeding, then by increasing the IOP to 60, the bleeder stops bleeding, and then you can diathermize it.
Okay, sir.
That's one of the main features. Reasons, one of the main uses. It stops bleeders momentarily, and for that you then use the diathermy, or it just stops on its own, and then you can bring back the IOP to 20. But you can't keep operating at 60 only, because this happens in cases and then they get pale disc and good vitrectomy done with a pale disc. That actually means the disc perfusion got affected because of keeping the IOP at 60 for a very long time. Continue.
This is a console or the user interface of the vitrectomy machine. Now we come to the fluidics. The IOP control in the eye is controlled by two things: the infusion, which is coming, or the inflow, and the aspiration, that is the outflow. Infusion can be two types: the gravity fed and the vented gas force infusion. The vented gas force infusion, pressurized gas forces the fluid out of the infusion bottle. So our Constellation uses VGFI with specialized IOP control systems. In aspiration system, it is of three types: the peristaltic, venturi, and combined. The duty cycle control, which I explained you earlier, it has three modes: the core mode, the 50-50 mode, and the shave mode. In core mode, the port remains open for majority of the time, or more than 50% of the time the port is open. So in such cases, when you are doing the central vitreous, when you are going in the core of the vitreous and the retina is too far, then we need more bite of the vitreous to come into the vitreous cutter. So we'll keep it in the core mode. So amount of time the mouth is open is more in cases of core mode. In case of 50-50, it is same like our electrical, where the duty cycle is 50%. 50% time the port is open and 50% time the cutter mouth is closed. In shave mode, what we have, shave is usually done in the periphery or when we are very close to the retina. So we do not want the retina to jump and come within the vitrectomy port cutter. So in such cases, we want the port to be closed for maximum majority of the time. So in shave mode, the duty cycle is almost less than 50% all the time. So the Constellation, now we deal with the vitrectomy mode. The Constellation comes with three vitrectomy modes. First is the proportional vacuum vitrectomy, in which when you put, in which the cut rate of the surgery, in which the cut rate is fixed, but when you press the foot pedal, the vacuum changes. So in proportional vacuum vitrectomy, cut rate is fixed, and what you are changing is the vacuum. In cases of 3D, both suction and the cut rate can be controlled with the foot pedal. But in cases of momentary, when you press the foot pedal, the vacuum will increase linearly, but the cutting is only on the demand when you press on the side kicks. So we can see in cases of proportional vacuum vitrectomy, cut rate is constant, vacuum increased. In cases of momentary, cut rate is usually kept as low, because in momentary usually the cutter acts like a scissor and the vacuum is increased with the help of foot pedal. And in case of 3D vitrectomy, the cut rate reduces when you press the foot pedal and vacuum increases correspondingly. Now we come to the adjuncts. In adjuncts, we use PFCL because of its high density and specific gravity. It is used to flatten the cornea. Sorry, it is flatten the retina. Then it is optically clear, so laser can be done under PFCL, and it is used in PVR, GRT related RDs, in cases of foreign bodies and dislocated IOL. It can be used as a tamponade, but it is very toxic both mechanically as well as chemically. Silicone oil. Silicone oil has a specific gravity of 0.97, so it floats in water. It is heavy. It has 2 centistokes, 1000 and 5000. 1000 centistokes is the most commonly used in our settings. It is used in cases of RD where long-term tamponade is needed. Then we come to the gases. The property of gases is buoyancy, surface tension, and interfacial tension. And the dynamics is expansion. First, when you put the gas, it expands, then it equilibrates with the nitrogen gas, and then there is a dissolution of the gases which you have put. So this table explains that the isoexpansile level of SF6 is 0.5 ml and for C3F8 is 0.3 ml. The maximum expansion of SF6 is 24 to 48 hours, and C3F8 is 72 to 96 hours. These two are the most common gases which we use, SF6 and C3F8. Now we come to the dyes and what is a chromovitrectomy. In chromovitrectomy, when we use basic vital dyes, what is a vital dye? The dyes which are used to stain the living structures like ILM and vitreous, these are the living structures, so it is called and these are non-toxic dyes, so they are used in chromovitrectomy. The most common one which we use is BBG of 2 concentration 0.025% and 0.5. It stains the ILM basically, but it is also used in ERM removal because of the negative staining. Now we come to the basic steps in vitreoretinal surgery. First, in cases of the trocar is held, the conjunctiva is displaced, and first we go linearly and then we go towards the vitreous cavity. In the infusion cannula, never start the infusion cannula without seeing the port, whether it is in the vitreous cavity. Never start the infusion without seeing whether the port is within the vitreous cavity or not. Because if it is not in the vitreous cavity, it can lead to suprachoroidal hemorrhage. Standard infusion cannula which we use is 4 mm cannula. The superior sclerotomies usually should have an angle of at least 160 degree between them, and they should always be put at least 1 to 1.5 clocas above the horizontal meridian. And the infratemporal or the infusion port should be always made just beneath the insertion of your lateral rectus, because in such way it will not hit the lower lid or the lower lid speculum. Plus, in some cases, when you are inverting the eye downwards to do the inferior vitrectomy, sometimes if it is your infusion cannula is very low, it can go into the suprachoroidal space and cause suprachoroidal hemorrhages. Then comes before starting the main vitrectomy, we should always go ahead and do the anterior hyaloid vitrectomy. Then for the core vitrectomy, it always proceeds in antero-posterior manner. First you do the port side, then anterior, then core, then a PVD, and then peripheries. Then the sign of vitreous attachment is a fish strike sign. You can see the green tip of the extrusion tip is just bending during the active suction close to the disc. It means some amount of hyaloid is still there over the disc. And similarly in wave sign, you can observe the wave on retinal surface as functioning cutter is passed over the posterior retinal surface. Now we come to the PVD induction. In PVD induction, usually at 400 to 500 mm of Hg is applied over the nasal of the disc, and hyaloid is grasped either with a vitrectomy cutter, or sometimes some people use an extrusion tip, and sometimes some people also use your microvitreal forceps is also used if the PVD is if the hyaloid is quite thick. Recently, a new method of PVD induction called drunk walk method was introduced by Dr. Philip and Dr. Garg, in which hyaloid is engaged over the disc and move over arcade in side-to-side staggered motion. Now for peripheral vitrectomy, that I told you, you should always do in a shave board in which and the vacuum should be reduced and cut rate should be increased. Light pipe should be positioned as perpendicular as possible to the vitreous for its optimal visualization. As we all have seen sir doing interface vitrectomy, which is done under air, in that way the vitreous is more clearly visible. Now we come to the fluid air exchange. In fluid exchange, the extrusion tip or the cutter tip is directed always towards the disc, because we do not want, as we go close to the retina should not come into the cutter or the extrusion tip. The SRF can be drained to settle retina via retinotomy or a break. Now for the endo laser photocoagulation is used to seal the retinal breaks. It can be done either in the repeat or in the continuous mode. Now closure of the port. The infusion is usually set as 25 to 40 mm of Hg. Cannulas should be withdrawn at the same trajectory as they were inserted, and conjunctiva should be repositioned back. In cases of 25 years, sometimes we do not suture the port, but usually we go ahead and we suture our ports most of the time, because for preventing wound leak, or there was a prolonged surgical time, excessive manipulation in the eye, or resurgery, or in cases of myopes. Now there is a small retinal detachment surgery video, and this conjunctiva is displaced. Then first we went at 30 degree, and then within the vitreous cavity infusion cannula is put. Similarly, the superior ports are being made. Illumination is now anterior hyaloid vitrectomy is being done. This was a myopic patient. In this way, PVD was already there. So now we are cutting the vitreous in the shave mode. Now tricot is injected to reconfirm whether PVD has, there is some amount of anterior hyaloid film is still there on the retinal surface or not. The vitreous based shaving is being done. Now retinotomy was made and hyaloid was and SRF is drained. We can see the SRF draining out of the subretinal space. This is called the Schlerin effect, where you can see the SRF is draining coming out of the retinotomy incision, retinotomy site. This is a fluid air exchange. And then photocoagulation of the retinotomy site and the break. Then the ports are sutured. These are the suggested reading. You can read these books to understand more about the vitreoretinal surgeries. Thank you. I would give a special thank you for Professor Atul sir, Dr. Rohan and my colleagues for all the inputs. Thank you.
Anybody has any questions? Are they there in the chat box?
There is a question from Diksha. When do we use 50-50 mode?
Sir, 50-50 mode is not used currently. Mostly for core we use for the core vitreous we use the core mode, and for the shaving we use the shave mode. 50-50 is not used in present settings.
Any other question? Abhijit, have you taken the attendance?
Yes, ma'am, attendance has been taken.
Okay. From the YouTube also and from here also.
Yes, ma'am.
No.
Yes, ma'am.
Kanusha, there is another question for you. What are the problems in myopic eyes and how to overcome?
Sir, in myopic eyes, basically the sclera is quite thin. So there is always a chances during the vitrectomy the ports usually come out. So it's better to make a biplanar incision in such cases. Plus, you should if the axial length is too high, like 32 or 34, we can and you are not able to go within the posterior pole of the at the posterior post, you can remove the micro-cannulas and you can directly enter with the cutter in such cases.
Okay.
And MIUCTs are useful in cases of myopic eyes. You can feel nicely while seeing because the retina is quite thin, so feeling and all is easy if a MIOCT guided surgery is being done in cases of myopic.
What is the field of view of Chalon lens?
So 30 to 40 degree mostly.
40 degrees.
I think vitrectomy is shown in the surgical viva also, isn't it?
Yes.
As a surgery?
Yes.
All the steps and all you have to know. Eye banking you will be asked in your grand viva. Then
It also comes as an essay type
whenever
question.
there is a field. Essay
It
type
comes as
question
an
and they
essay
can
type
ask
question.
you They can ask you anywhere if there is a keratoplasty related case, then they can ask you as a short case, as a spotter, it can come anywhere.
Anusha, there is one more question for you. Uh, how do we know when oil injection is complete or adequate?
Sir, either you can put the oil while looking at the vitreous cavity. So you can see when the oil comes at the level of the oil comes at the tip where you are from where you are filling the oil. If it is coming at at that point, then you can just remove the wide angle. You can visualize. If you can see a air and silicone oil meniscus, if it is in the primary position, it means the eye is adequately filled. Or sometime in the infusion cannula, you will see just the oil coming up in the
Okay.
infusion cannula. Then also you can stop filling the oil and you can palpate on the sclera to see whether the IOP is fine or not.
I think if it comes through the port, then that means
Yes,
you
sir.
have overfilled,
Sir,
right?
actually we are using non-walled currently, so the oil doesn't come from the port. We can only see it in the infusion cannula. It rises up in the infusion cannula. If it is rising, it means it's slightly higher, which we require.
So mostly it's the meniscus
Yes,
most of the time,
either meniscus
practically.
or that if it is coming in the infusion or
Okay. What is plus in 25 plus?
sir, plus is the stiffening sleeve. Actually, 27 and 25, these are very thin, so they are very malleable. So they have a
Okay.
stiffening sleeve present. So those instruments are designated as 25 or 27 plus.
In one of your slide, you have mentioned lesser the gauge, the more is the thin. I think that's the
Yes,
typo.
sir.
No, higher the gauge, thinner is the instrument,
Yes, sir.
right?
Yes, sir, I have explained it.
Okay. Any specific points we need to take care during end of vitrectomy in surgical step?
Sir, end of vitrectomy, as a junior when I came, my seniors told like do not go into the periphery because you don't know, the vitreous is so thick. We won't be, if we go in too much periphery, if you make a break, you won't be able to laser it and you won't be able to even visualize it. So better you do a core vitrectomy. Once you visualize the disc and the macula, just come out and put an intravitreal inside. It will go with it. Just you have to debulk. You don't have to do an entire complete vitrectomy in such cases. You have to just debulk the infection and come out.
Okay. How do we assess underfill or overfill in oil filled eyes post-op?
The first thing is the IOP itself will show you, and then even the meniscus you can see. If the meniscus is seen in the
No, no,
primary
I think
position,
he's asking about post-op.
sir, underfill oil you can see, in the meniscus also. When you see with an IO, you can see a full-fledged meniscus with the indirect ophthalmoscope. If it is an underfill, in an overfill, you have to make the patient see up and down. Then only you can see the meniscus.
Okay. I don't think any questions further. Any further questions are there for you?